A very good afternoon to everyone. Thank you for joining Medflix 2021 virtually from the comforts of your home or practice. The topics that we're discussing now will be verified today for a better tomorrow. Time matters. My name is Jun. I will be the moderator for today's sessions then. Before we proceed, we have few of those housekeeping details to go through with you. The live sessions today will work based on webinar formats. The speakers will be delivering their various talk, followed by the panels or Q&A. If you look to the right side of your screen, there is a button, Present, which you can click and submit the questions. Throughout the system, you may opt to put your questions up in these panels. The questions will be directed by the session moderators to the speakers to discuss if time permitted. Without further ado, I would like to introduce our speaker for today. Our speaker for this session is Prof. Chance, consultant endocrinologist from SJMC, where she is also holding an honorary professorship at the Department of Medicine, UNMC. Prof. Chance spends most of her careers in academics, teachings, and molding the minds of the future doctors, and is proud to count by many senior consultants and professors who were her students. She is also an active researcher who is involved in the fields of diabetes, endocrinology, and osteoporosis. Recently, she chaired the 2020 Malaysia CPG guidelines for the management of type 2 diabetes, which may change doctor approach in managing diabetes patients. Prof. Chance is the current president of Malaysia Osteoporosis Society and Malaysia Endocrine and Metabolic Society. Her valuable insight in the strategies of type 2 diabetes management will be eye-opening sessions to everyone here.
Thank you.
Please welcome Prof. Chance.
Thank you very much, June. I should have told you not to introduce me like this, shy only. Okay, so for the next 45 minutes or so, I'm going to have to talk to you about Verify. I think the verified data came out about 2 years ago, and this is changing practice. And I hope that after this talk, you might also change your practice. So here we go. I think some of you or many of you would have heard this main verified data, but bear with me, I will show you the Asian cohort to see how the Asian type 2 diabetic individuals differ from the overall cohort. So managing type 2 diabetes, I'm sure you and I are more than familiar with the criteria for diagnosis of type 2 diabetes, that these individuals have to have levels that are elevated for either glucose or A1C. All right. So what is the burden of diabetes in Malaysia? You have seen this as well. We have out of our 30 million Malaysians in the country, almost 4 million above the age of 18 have diabetes. You calculate that 1 in 5 adults in Malaysia have diabetes. 1 in 5. That's a huge number. And you look at this prevalence, you will see very, very quickly above the age of 40, the numbers jump 20%. Up to 60 years old, it's about 30%. 60 and above, you are talking about almost 50% of people in Malaysia have diabetes. But I want to focus on this because I think this particular topic that I'm going to talk about is relevant to the young people who have diabetes at a young age, which I will shorten to young onset diabetes, YOD. In that population census done in 2019, we recognize that below 30, that means 18 to 30, 6% of people have diabetes. That makes 1 in 16 people below the age of 30 have type diabetes. Much of it is type 2. If at the age of 30 to 39 is 11.7%, how does that translate? It translates to 1 in 8 people in that age range of 30 to 39. 1 in 8 have diabetes. Those numbers to me are very frightening. Why is it frightening? It's because you think about it. If I have diabetes at the age of 30, I expect to live till 70. I'm going to be living with diabetes for the next 40 years. If I have diabetes at 20-something, it's going to be close to 50 years living with diabetes. And you can imagine if the sugar is not well controlled, you are going to accumulate the complications from being poorly controlled. So the next question is, I think, important. What level of A1C should I have or a patient have if I'm considering taking a pill to improve glucose control? So then the next question that you will ask me is, SP Chan, when does glucose control matter? All right. And the answer is as long as it is above 7%, you're going to start seeing complications. Just focus on the right of this slide, which looks at the incidence and prevalence of retinopathy. And I'll just highlight for you because it's going to be quite small. Any A1C above 7%, you can see that increase in prevalence of retinopathy going up as soon as the A1C is above 7. That is that pickup. And that's the reason why many guidelines have chosen 7% A1C in order for you to say, the higher you go above 7%, I'm going to start seeing complications of diabetes. And on the left panel of this slide, you will recognize the famous UK-PDS. And again, you can see for every level of A1C that they go up above 6 to 7%, you're going to start seeing increasing prevalence of microvascular complications in the red, and in the blue. In the blue is the microvascular complications, and in the red is macrovascular myocardial infarction. So these data convince us clinicians to say, look, if I have a patient with high glucose who's diabetic, I want to try and push the patient down to less than 7% because I know higher than 7% is going to start seeing more complications. Again, just to try and remind everybody, there is a legacy effect. And this is seen again from that famous UK-PDS that you are very familiar with. First 10 years from the time that they were diagnosed to have diabetes, good control for the next 10 years during the first part of the UK-PDS, and then the subsequent 10 years, they were able to reduce microvascular complications by this amount. During the follow-up, invest in the future. The lower the A1C, the lower the complication rates, not immediately during the time that you are treating the patient, but even in the future, there is this legacy, this memory of good glucose control. It is worthwhile. Okay. So then the next thing that I think I need to spend with you is, what is the definition of YOD, young onset diabetes, and what is the definition of older adults with diabetes? Older adults is recognized as above the age of 65. That's late onset diabetes. And young onset diabetes is depending on, it's not specific. There's no definite overall global guideline. In the Asian countries, part of the JADE countries, we use below the age of 40. That means if you have diabetes younger than 40, you are is considered as having young onset diabetes. While in Europe and the rest of the world, they think 45 or lower is considered as young onset diabetes. And again, I'll explain to you why in the subsequent slides. This is the Malaysian CPG guideline that was just recently launched in January, late January, delayed because of the COVID. And we have determined that in most people, we should aim for 7 or less. But in patients who are new onset, young, uncomplicated, we want to aim even lower at 6.5%. The text is here. Less than 6.5 if you have a short duration of diabetes, you don't have any significant comorbidities, expect to live a long life without any risk of hypoglycemia. And these are the range of glucose that we need to try and aim for in order to get that A1C target of 7 or 6.5. And this is the American Diabetes Association numbers, 7%, and you can allow them to go to 7 or 10, all right? So the next question is, should I start a single or combination treatment when I see the patient, right? So the first comment I will hear is, but SP Chan, you have always taught me I should give metformin. Is this enough? Should I add something else on top of metformin? And so here is again very famous data that all of you are familiar, just to re-emphasize that the longer the person lives and they live with the problem of diabetes, the poorer the beta cell. The beta cell is dying at a rate of about 5% per year. And so if the longer you have diabetes, this diabetes is going to progress and the A1C is going to start going up. On the right part of this slide, the UKPDS, you can see going upwards the longer they have been diagnosed to have diabetes, suggesting that diabetes progresses and beta cell is dying as they have longer duration of diabetes, and you need to consider adding treatment. And this again, another slide which I have shown from the UKPDS. They had a small group of patients with overweight, and they actually randomized them to receive metformin. So in the orange panel, you see metformin here, and you can see within 3 years, the percentage of patients that were able to get to the less than 7 was only 44%, which means that almost 60% were above 7% 3 years after the diagnosis of diabetes. 6 years after the diabetes was diagnosed, only 34% were at A1C of less than 7. That means 2/3 of the patients were already having a A1C above 7. And when it is 9 years from the onset diagnosis of diabetes, you're talking about 13% who are able to control with only metformin alone. And that means about 90% should be on additional medication. This again spells the fact that diabetes progresses, you have to consider adding medication. So let's talk about what do we see in Malaysia? We see that our patients are not doing well at all. I'm very embarrassed whenever I show this data. Only 22% of our patients, when we did the survey in Diab Care, had a A1C less than 7%. This is lousy numbers. You turn it around, it means 80% of people managed in Malaysia don't have A1C that we want, that they are above 7%. So then the next question is, SP Chan, how should I consider adding medicine earlier so that I can stop them from failing? All right. So let me start with these questions, and I'd like you all to try and answer them. Don't worry, I can't see who you are. So what target would you aim for in this man? I don't know how you can answer. Actually, this one, no, I don't expect you to answer this because there are too many variables. 60-year-old man with cardiovascular disease, would you want A, B, or C? Guys, think about it. I hope many of you will at least say B, and it should not be C. All right? Now, B, a 40-year-old woman, a young onset diabetes with no comorbidity, just that she's overweight, what level of A1C would you want for her? Would it be A or B or C? Less than 6.5 or less than 7? I hope that the answer from you guys are less than 6.5. What about a 35-year-old man who just happens to be very sedentary, very poor diet, sitting in the office all the time, so has gained a lot of weight, is hypertensive, diabetic, and overweight, but has no cardiovascular disease? Would you aim for 6.5, 7, or 8%? And I hope many of you will choose 6.5. He is 35. And think about it. Oi, what happens if it were you? It was you. How old are you? What number would you want? What would be the empat echo number that you want for yourself? Okay, now let me go to question 2. This is where I'd like to, would you start medication in any patient whom you see whose A1C is less than 6.5, less than 7, or less than 8? How? Okay, I don't know how. I didn't build it for you to answer. Okay, let's just give me which is the number that you will start a medication. The lowest number you will start a medication. Please answer. I don't see anyone answering. I don't see it 0, 0, 0. Are they able to answer? Okay, right. I'm seeing some answers coming through. Okay, good. Please answer. Please answer. Just to keep you guys engaged, so that it's not just listening one way street all the time. I already see one question. Not to worry, I've seen it, so I will answer it. Okay. Oh, brilliant. Okay, good. Let's stop it. We have 60% who say less than 7, 20% who says less than 8, and about 20% who says less than 6.5. I tend to agree with those of you who would suggest at least less than 7. I would start medication. I think less than 8, that being your lowest number. Okay, maybe I also wrote the question wrongly. Sorry about that. Okay, let me start my slide share again, because I think every time I ask, oh no, sorry, I have to share. Okay, if the patient's A1C is less than 7%, what will you start with? A, metformin alone, B, DPP-4 alone, such as vildagliptin, or C, metformin plus vildagliptin combination, or D, metformin and SGLT2. Let me add another aspect of this patient. This patient is not obese. This patient is not overweight. What would you choose? Please answer. Okay, good. So 80% metformin alone, 9% vildagliptin alone, 10% taking metformin and vilda, and 2% metformin SGLT2. Thank you so much for your participation. That's very helpful. Okay, so I hope to perhaps change your mind, those of you who have said metformin alone, 80% by this next few slides. Next, let's go. Okay, sorry. So let's look at the Verify study. Okay, the Verify study actually came out a little while ago. What they were trying to do is to try to change this trajectory. This you will recognize is the A1C trajectory in UKPDS patients, in those newly diagnosed overweight metformin treated patients. It improves, and then within about 2 to 3 years, by about 3+ years, they start going up, and they lose control as defined by A1C above 7% by the end of the 3rd year, going to the 4th year. And then they continue to shoot up, suggesting that metformin itself alone will fail to control patients to A1C below 7% by the end of the 3rd year after being diagnosed. And they were hoping that with the combination of metformin plus a DPP-4 like vildagliptin in Verify will keep them on this trajectory so that they don't lose control. That means basically they want them to have a combination that is more durable. Boleh tahan macam our battery, our okay, tahan lama. Okay, so here they were trying to see whether or not time to treatment failure, and they define time to treatment failure by A1C going above 7% 2 times. So every 3 months they do the A1C. If the A1C is above 7% twice, that means over a 6-month period, that person is considered failed treatment and they need to be escalated to additional medication. Okay, so this is where the patients were from the time of duration of the time they were diagnosed to have diabetes. Within the first 2 years of being diagnosed, they were started on into the Verify study. as compared to only UKPDS and ADOPT study had patients who were recruited soon after diagnosis. All the other studies that you are familiar with are like ACCORD, like the most recent studies like EMPA, CANVAS, were all at least 10 years to 15 years after being diagnosed to have diabetes. So you are having a very much more newer diagnosed patients. And you can see that the A1C, which is that broken line, most of the patients in the VERIFY study had A1C below 7%. Majority of the other patients in the other studies had A1C above 7%. And the higher they are, the higher the mean A1C of that group of recruited subjects. So you can see the A1Cs were much higher in these patients, while VERIFY found patients who had A1C of 7 or below. So, okay, type 2 diabetes, less than 2 years, but in actual fact, many of them were about 3 months after diagnosis. Their A1C had to be less than 7.5, all right, and can be between 6.5 to 7.5. As I mentioned, the first period is 6 months. During that period, there was 2 arms. One was metformin plus Vilda. Of course, they didn't know lah. They were blinded to the medicine. They just swallowed the pill. Okay. The other group was metformin plus placebo. And for 2 consecutive A1Cs, A1C at 3 months, A1C at 6 months, if their A1C was above 7% in the metformin placebo arm, they were initiated on addition of vildagliptin here, move to the combination. Okay. And this was what is defined as initial primary treatment failure. But this group of patients who were blinded to the treatment but were already on double therapy, it doesn't matter what the A1C is, they could not change medication until the end of the 1 year period. Another 2 more times of doing A1C, if they are above more than 7%, then they were added insulin. Or both groups added insulin as the third agent in this trial. And that was determined, anybody starting on insulin treatment at the end of 12 months is considered as secondary treatment failure. Okay, so let me just sort of say again, primary failure is failure from beginning of treatment. Okay, beginning of the going into the study. All right. The second treatment failure is whether or not combining the treatment at the beginning versus combining the treatment only when they fail, whether or not this was which regimen was better. So this is the treatment. We had a few patients from Malaysia as well as Southeast Asia. So you can see that out of the 2,000 patients, about 20% were from Asia. So let's look at the proportion of patients who were failing metformin placebo versus the patients who were randomized to the combination from the first day of recruitment. And you can see very clearly that those patients who were in the combination, early combination from the time they were recruited, they had a lower failure rate. That means they didn't lose A1C above 7%, much lower than those who were started on metformin, then add vildagliptin by up to 50%. So that actually, if you look at the 50% failure rate of the patients who were on metformin single therapy, then add vildagliptin, 50% of them failed and had A1C above 7% by the end of 3 years. Does that sound familiar? Yeah, they look like UKPDS patients, right? Now, the patients who were started on combination from the beginning, 50% of them failed only after 60 months, after 5 years. So you were able to have a longer duration where the patients were still at A1C of less than 7% by as much as 2 years. All right. So you dragged out the failure rate by extra 2 years. So it means that this study showed that giving a combination metformin and Vilda, you get more durability of control of sugar by almost 50%. Then what happens if at the end of 12 months, what happened to those who were combined from the beginning and then continued? You can see that the failure rate was still slower than those patients who were started on metformin alone, then only add on metformin. So by as much as 26%. So this is what we call a legacy effect of initially starting off you drag out the failure duration, and on top of that, further along failure duration is even continued. That means this investment is still seen, that the loss of control is slower than those patients who were on metformin and followed up with subsequently. Then you will be thinking to me, SP, show me which are the patients who benefited most from this early combination. Doesn't matter. You can be fat or not fat. BMI less than 30 or more than 30. You can be young or old, less than 50 or more than 60. Still, the benefit is the early combination is able to give you a longer durability. And it also doesn't matter whether you are a guy or a lady. Okay? So it doesn't matter. The failure duration, the prolongation of the duration of improvement is prolonged, irrespective of how old you are, whether you're a guy or a girl, or whether or not your A1C was high or low at the beginning. Okay, I didn't show you there. Over here, A1C above or below 7, also you see that the loss of failure was dragged out. Okay, so this was to me very important because it tells me that early combination, you can tahan lasak longer. The ever-ready battery lasts longer. That if you start off with combination versus one after the other, there is a difference in the benefit because it actually, again, that durability is seen. So next, I promise you that those of you who have seen the earlier data, your SP, or I can regurgitate it already. Let's look at how the young diabetic individuals performed. We know that young onset diabetes is more common in Asia. You would have seen young patients with diabetes, especially if they come with their parents, right? That's what I usually do. My patients are coming, bringing their children along. And we know that Asians can benefit from treatment that will preserve the beta cell. Okay, right. So next, why is young onset diabetes a problem? And this is data from the European countries, and they define it as less than 45. So that's the reason why they stop 45. 2 times more likely chance of having a heart attack or a stroke. 14 times more likely to have a heart attack compared to those who didn't have diabetes at a young age. 80% more likely to need insulin for control. All right. And is it very common? The answer is yes. 1 in 5 adult patients have young onset diabetes. And HbA1c is higher in the young onset patients versus the late onset diabetes. You can see the mean A1C from this verified trial. Okay, so, and when they looked at young onset diabetes, 35% of the patients who were recruited from the Asian countries were from Asia. From the overall cohort was from Asia. Okay, and you can see that about 10% of the verified cohort was young onset, while the 17% of the older onset, late onset provide 17%, no, sorry, not late onset, 17% from the non-Asian countries, okay, 17% of their cohort. So here I showed you already the overall cohort. 36 months for failure of 50% and 61 months if it was in early combination and a prolongation of 2 years, right? And this is the young onset diabetic subgroup. You can see 50% of failure by about 27 months, earlier by 10 months compared to the overall cohort, and 42 months versus 62 months, earlier by 20 months failure rate in these individuals. Okay, so that if I were to look at the statistics, you delay loss of control by almost 50% compared to other individuals who were given just metformin alone. I'm going to blow up this and show you the secondary treatment failure and just show you that by the end of 5 years, 60 months of this verified study, you can see patients failing in the single arm followed by an addition only when they lose control. While when you start on an early combination, you can see that only 50%. So an extra 20% had lost control in the one by one followed by the other versus the early combination of both at one go. So a reduction in 48% of treatment failure in those who had young onset diabetes. Okay. If you look at the data from a slightly different way, looking at patients who had less than 7% A1C at the end of 5 years of the Verify trial, in the overall cohort in the Verify, in the early combination, straight up front from first day you're on combination, you have 56% who had A1C less than 7, while about 38%, about 18% less who were controlled at less than 7% in the 1 by 1. While you can see here, young onset diabetes, 50% of them were at less than 7%, while about a quarter of them were able to achieve less than 7%, meaning about 20% of them had lost control if you start off with 1 by 1 treatment. One fail only, then start the second one. Okay, so what did we learn from this verified trial? That early combination of a DPP-4 like vildagliptin plus metformin, it works for both young and old. So you can use it, and it will prolong your duration of ability to maintain control. While young onset patients, they have actually loss of control much faster by 10 months and 20 months. I showed you earlier on. And then when you give the early combination in the young onset diabetic patients, you are able to prevent their failure by up to about 48% versus 26%. Okay. So the summary is, from Verify, the earlier you control them, and with better glycemic control, it ends up being more durable. And because you're using metformin and DPP-4 like Vilda, you won't have an excess risk of hypoglycemia. And because these two drugs don't cause weight gain, the patients will not gain weight. Okay. And it will reduce your chances of losing control and clinical inertia. So what has the new guidelines suggested, given this very important study? This is from the ADA. The ADA 2020, all right. So consider early combination in patients to try and extend the time to treatment failure. That means you actually increase durability of maintaining A1C below 7%. And this was considered level A, highest class of clinical evidence. And this is from our latest CPG. So I'm only showing half of this part of the algorithm. If your patient has lifestyle modification and A1C is less than 6.5% or between 6.5 to 7.5%, consider monotherapy here, consider mono or dual therapy here. I want to highlight, I know it's not easy to see, this lowest part of this particular column. If the A1C starts going above 6.5, this is what we have classified. If it goes above 6.5, we have added this clause, consider addition of DPP-4 like vildagliptin, referring to the Verify study. Metformin plus vildagliptin delays loss of glycemic control when initiated within 24 months of diagnosis. So we have also incorporated this very important clinical data to our algorithm and recommendation for clinical decision making. So more than 6.5% consider addition of DPP-4 plus metformin. So we know that vildagliptin is effective across the diabetic spectrum. You can use it without causing hypoglycemia. It is effective. You can use it in renal impairment. It will still be effective at lowering A1C. It doesn't give you the additional cardiovascular benefit, but it is safe. There's no major adverse effects like urine infection, balanitis, DKA. It's very good and effective. And you can use it even during Ramadan when patients are fasting, because you don't have to worry about them becoming dehydrated when they are fasting and not able to drink, right? So across the entire diabetic spectrum, from early onset to late with renal impairment, if they have cardiovascular problems, you can still use a DPP-4 like vildagliptin and still improve glucose control, because you know glucose control matters. But the Verify study actually told us something more, that if I have a young onset diabetic patient consider combination because they will lose control faster than the older onset, and that the durability of this initial combination has been proven in this study. If you start with two together, 2 in 1, all right, boleh tahan lama, tahan lasak, all right, and they will last longer, and hopefully they will not need initiation of insulin quite as readily. Okay, with that, thank you very much for your attention. I have finished, and I think I have now 15 minutes to answer questions. So I have seen some questions earlier on when I was posing the questions. I have lost that question thingy. Okay, so there were some questions that I've already copied down, which is if a patient is already on insulin, okay, is there a potential that they can switch back to oral drugs and omit the oral drug eventually? The answer is possible, but not definite. Okay, if I have okay, Mr. June, Dr. June, can you answer, because I've got this very urgent call from the hospital. Can you just give me a few seconds? Please take over.
Sure. Thank you. So we have couples of questions, quite a number of questions that is listing out. Then I'm actually arranging all these questions right now. So in the meantime, we just give Prof chance for a short period of time. Well, but feel free to put in all your questions if you still have any. We'll try to address it with the limited times that we have at this point of time. Hello,
okay, sorry about that. That was glucose. Right. So I have seen, hang on. There was a question on insulin. The insulin, if you have a patient who's not very thin, who's not likely to be beta cell exhausted, who's on insulin perhaps because they were having an acute stressful event like an infection, like let's say COVID, okay? And then they get better. And they go home on insulin because their sugar was so poorly controlled during that infection. Then when they get better, they have had a fright of their lives, and they now say, SP Chan, I'm going to behave myself, I'm going to lose weight, I'm going to go on diet like you told me all the while, but haven't really done so. And they lose weight. The answer is yes. If they lose weight and they start on a lifestyle, they can potentially switch back to oral drugs. And particularly if sometimes some patients start on SGLT2 and a DPP4 and get to control, and they've lost a significant amount of weight, they may not need insulin. But please, a big but, don't say SP Chan say can switch, go back and then switch all your insulin patients to SGLT2 and metformin. No. You have to look at the patient, how easy it is to control, and then maybe cut down the dose of insulin and then work from there. Okay? Don't just simply switch off and then say, SP Chan say, because I will die. Okay? Then the next question was, HOMA. How is HOMA useful? All right? HOMA is useful for mainly research, and it doesn't help clinical decision making. All right, and it's for us academicians to sound smart to you. So basically, what we are looking at when we calculate HOMA is we divide glucose by insulin so that we can see whether or not the patient is making enough insulin. And if the patient has enough insulin, it means the patient is insulin, the beta cell is working, and they are maybe insulin resistant because they are overweight. So long story short, no need to ask a lot of things about HOMA. You look at your patient. If your patient got a big fat belly, all right, his BMI is high, this patient is most likely insulin resistant, most likely not going to require insulin, but some of them are, to be honest, all right? But so you don't have to worry about doing a HOMA. Even I don't do HOMA for my patients when they are losing control, okay? You look at the patient, you look at the A1C, you look at the fasting glucose, and you make a considered opinion on that, okay?
Sure.
Then there was a very good question on how good is Gymnemna tea, all right? That's a very commonly asked, similar type of question. Gymnemna tea la, or whatever else you drink instead of eating food. Basically, the answer is, if you drink something else that fills your stomach, that does not contain calories, that ends up with you losing weight, that will be good for your diabetes. It can be bitter gourd juice, it can be Gymnemna tea, but don't spend a lot of money on it now. Please don't do that. Okay? Now, the last question that I managed to capture was, why do we usually recommend basal insulin to be given at night? Very good question. All right? That is because, you know how basal insulin works, isn't it? Basal insulin is very slow acting. When you inject the basal insulin, depending on what insulin you use, if you're using like Lantus insulin, it will not have a peak. It starts working at about 6 to 8 hours, and it works throughout the next 12 to 24 hours. While if you use something like Insulatard or Insugen N from the Kementerian Kesehatan, it has a peak at about 6 to 8 hours, will last about 12 hours. Basically, it works throughout the night to suppress sugar from coming out from the liver. So it suppresses what we call hepatic glucose output. All right. So it switches off the sugar coming out from the liver. Why is it important? We recognize that people with type 2 diabetes have an accelerated, uninhibited liver that is releasing sugar throughout the night, even though you don't need it. Okay. And that is the problem. The liver is not sensitive to the circulating insulin. It's not responding to the insulin that is circulating. And so the flow is happily shooting sugar out. And that's the reason why you wake up with a sugar that is elevated. So the reason why we give the basal insulin is to switch that down so that they wake up with a normal fasting glucose. So they can imagine, those of you who play games, that if you give a patient who's starting with a normal handicap, your sugar won't go much higher. So that's okay lah. What is normal handicap? If I have a patient whose sugar is 5, 6, 7, after eating it will go to 8, 9, 10, which is still acceptable. But if you start off a patient whose fasting sugar is 10, after eating it goes to 13. So you have starting with a high handicap, that handicap goes even higher. So you want to start off the patient with a lower handicap.
Sure.
Got it?
Okay. Yes.
All right.
Thanks, Prof. Chan. We have a few more questions here. Can I read it for you, Sir Prof. Chan?
Yeah, why can't I read it myself? Okay, please read it for me.
Yeah, we have too many questions there. For those are newly diabetic patients with HbA1c less than 7, right? Is the combinations of metformins and vildagliptins a better choice, or the patient can start with the SGLT2 inhibitors? Which would be a better choice?
I think that was a good question because I put it in one of my question options anyway. All right. Again, the answer is not 100% this way or 100% that way. That is not going to be fair to your patient.
That's right.
Right? If it is, the question was less than 7.
Yeah, less than
newly
7.
diagnosed less than 7.
Less than 7, that's right.
Okay, let's say less than 7, but not like 6.5 or lower. Let's say 6.8, 6.9. And the patient is sitting in front of you and saying, Doc, I've been exercising. You look at the floor, he's thinner than you, he's fitter than you. Right? If that's the case, and the patient's A1C is still 6.9, I would start the patient on vildagliptin plus metformin. Why? Because I believe this fellow is having a problem with his beta cell because he's got a normal body mass index of 24, 25, is exercising as fit as he can get, as opposed to a different kind of person who comes in and looks at me and say, SP Chan, my BMI has been 33, 35 all my life. I've been struggling with a weight problem and now kena already because I'm diabetic. I'm so sad. Okay. That patient may be more appropriate to give metformin plus SGLT2 because you want an additional weight loss for that fellow who's struggling with a weight problem.
Sure.
But I have many patients who have young onset diabetes. That was the topic that I was covering and emphasizing today, is that the young onset diabetic patients tend to be slimmer. tend to have a BMI that is lower. And then when you take their waist circumference, or some of you thinking already, SP is not BMI, isn't it? It's waist circumference. Yes, you look at the waist circumference, they are actually not big around the waist. And these patients are more likely to have a beta cell problem. So DPP-4 will be more appropriate for them. Does that answer you? Yeah.
Sure. So there's another question is regarding the MGTT result. So this doctor encountered a case where the patients have a normal IFG and IGT, but the HbA1c is above 7. So in this case, if these patients are considered as diabetes?
Yes. Okay, maybe not. So make sure that the HbA1c is done by a lab that has good quality control. All right. Don't use the A1C that you do with the finger prick at point of care in your clinic office. Okay. Do a VD puncture. Send it to a lab that is good quality control, like Gribbles, like Path Lab, and so reputation good. All right. If the patient has no symptoms, you must have 2 values of A1C that are above 6.5 to be considered diabetic. 2 values if they are asymptomatic. If they are symptomatic, it's different. But the glucose tolerance test, the fasting glucose is not high, the 2 hours is not high. It doesn't mean that it didn't go up at around half an hour to 1 hour after eating. In some of these patients, I will then tell them it's not your 2 hours that's the problem, it's your 1 hour. That means the beta cell is lazy. During the first half hour, 1 hour, the beta cell doesn't push out enough insulin, and then you get a very high hyperglycemic peak, and then at 2 hours, zoom, it goes down because the beta cell catch up. All right. So the fasting in 2 hours may not capture the elevated at 1 hour. Okay. But if the A1C is 7% and it is duplicated in a reputable lab, that is unfortunately defined as a diabetic patient.
Okay, so it looks like we need to look for a reliable lab to get the proper testing done.
Correct.
So we have a questions on the HbA1c as well. These are the questions for the clinics who have difficulties in assessing the HbA1c. So can we use a capillary glucose to accurately titrate their diabetes medications?
That's a very loaded question. Well, some form of monitoring is better than no form of monitoring. All right. But point of care testing with the glucometers in the clinic or at home are very liable to mistakes, and they don't capture glucose 24 hours a day.
Sure.
So just as an illustration, the patient can cheat you no big time, right? 3 days before they come and see you, they will go on a fasting diet, and then when you see them, the sugar is nice. Then you say, "Oh, well done." The answer is not at all. Because the blood tipu you. And that's the reason why the A1C is important. Because the A1C will capture any time during the 3 months before they saw you, whether they've been naughty. All right. So in this day and age, unless you are staying in a real kampung ulu place where you cannot get A1C, I would suggest please find some way to get it done. Okay. The only problem is also is a little bit expensive. But the recommendation that most guidelines suggest is at least once every 6 months. All right. So don't just say one, because you're capturing that sugar at that point in time. 1 second versus 24 hours versus 3 months. Not possible. I think please try and get it done somehow, at least monthly. Okay.
Because the example that Prof Chang was given just now is exactly happens to my mother. So she was behaving her best for 1 week, then the capillary glucose is fantastic, but the HbA1c was off the chart.
And another expansion to that story is the patients, when you tell them to go home and do the glucometer because they say, "Doctor, I can do myself," right? They will come back with a nice book, show you the glucose reading, and all of them 100% fasting. Then I say, "Where's your 2-hour postprandial?" "Oh, doctor, I don't do." And then I say, "Why you don't do?" Because that one don't look so nice." So that's the typical answer. They know when they've been naughty, they don't want to check it. Right.
That's right. So the HbA1c is still remaining the gold standards in diagnosing.
I think so, because you will then be able to tell them, look, your risk of complications is high. The prognosis with regards to complications is made through the A1C. Yeah.
So we do have a question on the sulfonylureas. So the question is, do you think that it will worsen the diabetes in long run or it burden the beta cells? I heard about these questions quite often as well.
Yeah, it is very often. The answer is no.
Yes.
Sulfonylureas do not make the beta cell bankrupt, right? That you can use it and you do not have to worry that it will worsen the patient's beta cell function. Please, please, please. I get this very commonly and I get very frustrated. The answer is no.
That's right. That's right.
Okay.
Thanks, Prof. Chance. So even for those elderly with the HbA1c with 7.5, let's say the newly diagnosed with HbA1c at 7.5, do we still recommend with the dual medication therapy? Because we've been
That's a
talking about
very good question. That's a very good question. If it's an elderly, do I still work on giving them combination therapy if they have a A1C of 7.5? I hate to say I'm already elderly, okay? And if you come and tell me, look, SP Chan, I will be more relaxed with you, I'll come and hammer you, right? It depends on the patient.
Yep.
If you're elderly, okay, what's the definition of elderly? In Malaysia, elderly is actually above the age of 60. The rest of the world is above the age of 65. All right? If you're a good 65, and I think I am a decent 65, I would aim as low as I can safely go. But if you've got an indecent 65 who's all sort of like falling over, has had several strokes, can't even walk, that kind of thing, then you will be a little bit more relaxed with that patient. But again, I would like to turn the question around to you, the person who asked the question. Let's think about you. If it's your mother or your father who's at 65, who's walking around the neighborhood faster than you, fitter than you, would you want to get their A1C lower to prolong their quality of life? And if I can do it with metformin plus vildagliptin or DPP-4 that does not cause hypoglycemia, I don't have to worry. This is sort of what I call my security blanket, So I can give and then what we call in medical terms, fire and forget. I don't even have to worry because I don't have to worry about the hypoglycemia, right? And I know that it will work. And I can take it even before or after food. So easy. And if I can give them a pill like this that works and controls their sugar and keeps them longer, please, by all means, do it. All right? But you are right if you say that elderly person has got a poor quality of life, comorbidities, then you want to be a bit more relaxed with this patient, give a bit of TLC, give them medicines that won't cause problems. Thank you.
Thanks, Prof. Chong. I guess that because in Malaysia, our average lifespan is about 70-something, almost 75 right now. If they're diagnosed with diabetes at the age of 65, right, they still have about 15 years to live then.
Exactly.
That's right. So let's look into the next question. So this is actually related to the COVID pandemics one. They say that in the COVID pandemics, some of the patients may be on the long-term steroid and resulting they have a steroid-induced hyperglycemia. So these groups of patients, right, should we treat them with the metformin or we need to treat them with the combination therapy?
Okay, that's a very good question. If the patient has a need for steroid, whether it's because of COVID or not, and had developed glucose that was elevated, as this is called a stress-induced hyperglycemia, it will depend. It may be that you were diabetic and you never knew it and it was brought forward and made known to you when you were ill, okay? In those patients, after they recover, they may require treatment to control their glucose. But in another small cohort of patients, this really stress-induced hyperglycemia completely subsides after the stress is over and the sugars are completely normal. In these patients, they may not require medication. But we will diagnose them as stress-induced diabetes.
Sure. Thanks, Prof. Chance. I think that let me just ask for the one last question because we're overwhelming with a lot of questions right now. So
that's good.
Is there any difference in terms of the outcome between the early combinations of metformin plus the gliptins or metformin plus the SGLT or even metformin plus the vildagliptins?
Okay, I think that is a very good question. I think I will not be able to answer it theoretically because there's no study to confirm it either way. But it would sound logical that you can probably translate it to mean that if I can keep the glucose lower with the A1C that is below the target for longer, that I will be able to keep this durability for longer. Whether you do it with DPP-4 plus metformin or do it with DPP-4 plus SGLT2, I believe that you probably will see the same effect. But there's no proof. I'm just thinking aloud that you think about it logically.
Sure.
Of course, I mean, you can also turn around and say, if the fellow lost weight with SGLT2, can it be more durable? Sure, what?
Yep.
Right? So what else can I say? So that's what was proven. Okay, that reminds me. That was proven in the Chinese study. They took a bunch of newly diagnosed type 2 diabetic patients and put them on insulin. Some were on insulin pump, some were on basal bolus insulin, treated for about 2 months, ideal control. Then after that, they stopped everything.
Yep.
And after 2 years or so, they were still non-diabetic by definition of not needing sugar medication to control. So it shows that if you actually get the good glucose control early, you can actually get them to last longer.
Sure. I guess
ever ready battery.
Yeah, that's right. I guess that the goal is to get it with a tight control, then we will be a durability controller. Okay. So thanks, Prof. Chance again. Thank you very much for the sharing, and thank you all the audience with all your inputs and the questions as well. So our next sessions will be on the overviews of metastatic breast cancer. So that will start at 2 p.m. So stay tuned to join us later. And thanks again for Prof. Chan for the very insightful session. Thank you very much.